Hi, I'm Jackie Thelian, and welcome to Key Coding Tips. Today we're going to do myth debunking regarding Modifier 25. Let's first start by taking a quick look at modifiers and their function. Modifiers are two characters, numeric, alpha, or alphanumeric. CPT modifiers are numeric, such as Modifier 25, and HCPC modifiers are alpha or alphanumeric, such as QW to indicate a laboratory test is clear waved, or T1 to indicate the left foot second digit. Modifiers give us additional information about the service provided without changing the description of the service provided or CPT code. For example, a preventive and sick visit is performed on the same day. Modifier 25 does not change the description of the preventive visit, nor does it change the description of the sick visit. It does, however, alert the carrier that these two services are normally not reported to the same person on the same day by the same physician. But in this case, that's exactly what occurred. You are also telling the carrier that your documentation does indeed support both services. A complete list of modifiers are located in Appendix A of the CPT manual. Modifiers can unbundle certain services, alerting the carrier to pay for additional services. Because modifiers affect reimbursement, they're audited by Medicare, the Office of Inspector General, Medicaid, and many of the third-party payers. Since the utilization of Modifier 25 provides additional reimbursement, high utilization of this modifier will get you on the carrier's radar screen. Currently, the Office of Inspector General, Medicare, Medicaid, and third-party payers are aggressively auditing providers who have a high utilization of Modifier 25. So let's take a look and make sure we get it right. This slide and the next slide provide you with the definition of Modifier 25 as it appears in the CPT manual. In a nutshell, Modifier 25 alerts the carrier the E&M service was significant and separately identifiable from a procedure or other service provided by the same provider on the same day. The patient's condition would need to require an E&M service above and beyond the other service provided or beyond the usual preoperative and postoperative care associated with the procedure that was performed. The key words in this statement being significant and separately identifiable. Therefore, the documentation must clearly indicate additional history, exam, knowledge, skill, work time, and risk that goes above and beyond what is usually required for the surgery or the procedure performed. And this second slide just provides the additional information as it appears in the CPT manual for the description of Modifier 25. So let's do some myth debunking. Myth 1. Modifier 25 should be appended to an E&M visit every time the patient presents for a procedure. This is probably one of the biggest areas of confusion. You would not report an E&M each time a patient presents for a procedure. Many providers feel they're cheated out of an office visit if they only bill the procedure. The global surgical package calculates the reimbursement rate based upon the work included in the preoperative, intraoperative, and postoperative service. So you're getting reimbursed for that preoperative check as part and parcel of the global payment for the service that was provided. You're not being cheated out of an office visit. That reimbursement rate is actually included when they came up with the fee for the procedure that's being provided. For example, The patient presents to the physician and is instructed to come back next week for a colonoscopy. When the patient returns next week for the colonoscopy, you would not report another office visit, as the decision for the procedure was made last week. Additionally, that brief assessment of the patient on that day is bundled or part of the colonoscopy as part of the global surgical package. Okay, so I know what you're thinking. I can put down a different diagnosis and then get paid for the office visit and the surgical procedure. Merely putting down a separate diagnosis in order to get paid without medical necessity and supporting documentation will get you into a bit of trouble with the insurance carriers. The best advice I can give you is don't go there. In the end, you will have to pay back the money, and in some cases, there are other consequences that may be determined. Myth number 2. Modifier 25 should be appended to an E&M visit every time a diagnostic, laboratory, or radiological study is being performed. Many diagnostic and laboratory services do not require the use of Modifier 25 since they're not considered bundled into the office visit. This may vary from some insurance carriers to other insurance carriers, so it's best to check each carrier's policy. But many coders and billers append Modifier 25 to every E&M visit just to be safe and feel there is no harm in doing so. Well, as we mentioned earlier, overutilization of Modifier 25 will get you on a carrier's radar screen. Therefore, you're opening up your documentation to scrutiny by the carrier, not just for use of Modifier 25, but now your documentation is exposed for any other potential errors. Myth number 3. When using Modifier 25, you must always have a different or separate diagnosis. This is false. The definition of Modifier 25 clearly states separate diagnoses are not required. In this example, we see a patient presenting for evaluation of knee pain. The physician assesses the patient and documents a detailed history, and the physician decides to treat the patient's pain with a steroid injection. In this case, the diagnosis for the office visit and the injection are the same, being osteoarthritis, and the documentation clearly supports a significant and separately identifiable E&M on the same day of the procedure. This being because the physician documented a detailed history and physical exam, and we have components to support the medical decision-making process. In this case, the physician needed to first evaluate the patient to determine what the best course of action would be to alleviate the patient's pain. It's important to note, if the patient presented solely for the injection, you would not report the office visit. In some cases, the patient would come for a series of injections. In these instances, an E&M would most likely be reported for the initial evaluation of the patient and the decision to treat the patient with the series of injections. When the patient returns solely for their second and third injection, an E&M would not be reported since the decision for the injection was made prior to the date of the second and third injection. Additionally, that injection is a surgical procedure, which by definition includes that brief assessment of the patient prior to the administration of the injection. So once again, we see that this is part and parcel of that global surgical package. Myth number 4. I can bill an E&M with every preventive visit as long as I append Modifier 25 to the E&M service. In this particular case, you need to keep in mind you cannot double dip. A preventive medicine visit requires an age-appropriate comprehensive history, physical examination, and the ordering of any age-appropriate laboratory and diagnostic testing, as well as anticipatory guidance that's age appropriate. Therefore, you cannot count the elements of the preventive visit twice. You would need to carve out the positive findings from the history, physical, and medical decision. Those positive findings must be significant enough to support the elements of a problem-oriented E&M visit. For example, an infant that comes in for their preventive visit check and upon examination is noted to have a diaper rash. The physician informs mom to use some over-the-counter medication only if the rash becomes worse. On the other hand, a significant documentation to support a separate E&M would include the rash extending beyond the diaper area, notation on the physical examination of the rash being bright red, blistering, and oozing, and the history tells us that this has been present for a week, and in this case, the physician decides to treat this issue with some prescription medication. Once again, the difference comes down to the documentation indicating significant work of the physician or qualified healthcare professional, which meets those key components of the E&M service and goes above and beyond what is normally included in that preventive visit. Modifier 25 is utilized for instances where the decision to perform the minor surgery procedure is above and beyond that which is normally included in the global surgical package and supported by documentation in the patient's medical record. A minor surgical procedure is defined as any procedure which has 0 to 10 global days. So in the cases of minor surgical procedures, and that decision to do that particular procedure that day, as long as it's supported by documentation and the key components of an E&M, we would utilize Modifier 25. Modifier 25 is not used when the E&M resulted in a decision to perform major surgery. A major surgery is defined as a surgical procedure that has a 90-day global period. In those cases, Modifier 57 would be utilized to unbundle the office visit from the procedure. We also would not use Modifier 25 for an E&M visit by the same physician on the same day as minor surgery or an endoscopy, which is part and parcel of the global package. Insufficient documentation and no medical necessity. To learn more about it, click on the link on this slide and download the Medicare Global Surgery Fact Sheet. It's a great resource with valuable information about the global surgical package and more information about Modifier 25. If you have additional questions about Modifier 25, please ask them in the comments section below. Remember to stay updated and subscribe to Key Coding Tips. Thank you for watching.